In general, we care about blood pressure because it's an easy estimate of tissue perfusion. With a normal blood pressure, we can be reasonably assured that a person has good end organ perfusion, although I'll show there's some exceptions to that, definitely. In terms of measuring your blood pressure, there's the old-fashioned way of a manual reading, where you listen for your Corot cough sounds as you deflate your blood pressure cuff, and you'll get a systolic pressure when you start to hear these sounds and a diastolic pressure when the sounds disappear entirely. So you take your 2/3 of diastolic and 1/3 of systolic, and that gives you your mean arterial pressure. More conveniently, you can just use a regular automated blood pressure cuff now, which has an oscillometer inside of it. And I'll show you how that works. Basically, similarly to when you take a manual blood pressure, there's a cuff that will inflate past whatever the systolic blood pressure of the person is, and then drop the pressure. Meanwhile, the oscillometer is searching for vibrations which will start to occur when your cuff pressure drops below your systolic pressure. So let's say our systolic is here. We'll start to see higher amplitude oscillations, and these oscillations will actually peak at our mean arterial pressure. So the oscillometer actually directly measures your mean arterial pressure by finding the point at which there is the most vibrations. And then as you drop lower and lower down with pressure on the cuff, at some point these oscillations will sort of peter out. And actually the diastolic blood pressure is usually calculated with some algorithm that the machine has based on what the systolic pressure was and the measured mean arterial pressure is. But it'll be somewhere in here. It's sort of difficult to say what a minimum acceptable blood pressure is, but in general, for a healthy person, you may be able to get away with a blood pressure of 60. In fact, many people will walk in off the street feeling completely fine and are very healthy with a blood pressure of around 60 if they are young. Probably more wise would be to follow the rule of maintaining someone within 20% of their normal blood pressure. And then you know that they are probably being held in their safe range. Even 65 is kind of what people will say is a really safe minimum. But certainly pediatrics, some young women will tend to run at lower blood pressures without major issues. Various organs have the ability to auto-regulate their blood flow based on their needs. Basically, this works by arterioles that dilate in response to increased tissue demand or decreased supply. The idea here is that local vasodilatory metabolic byproducts are created by highly metabolically active areas, and then this causes relaxation of smooth muscle of the blood vessels and increase blood flow to those areas that need more oxygen. Let's look at cerebral autoregulation, for example. Cerebral blood flow is usually listed in mils per 100 grams per minute. And ideally, you'll be at around 50 mils per 100 grams per minute when you have metabolically active brain tissue. Your blood vessels in your brain have the ability to auto-regulate the blood flow when your blood pressure is between about 60 and 160 for people that have not shifted this range because of chronic hypertension, for example. So this is your auto-regulation range. And in here, in this range, a little bit higher blood pressure is okay because vasoconstriction can decrease the amount of blood flow so there's not excessive blood flow to your brain. Beyond 160, you're maximally vasoconstricted, and increased pressure will actually just result in higher amounts of blood flow to the brain, which certainly is not always a good thing. This can cause intracranial bleeds or even just hyperemia and edema in the brain. Normal blood flow through our autoregulatory range, and then starts to get dangerous below a mean arterial pressure of about 60, where any further decrease in blood pressure will result in less blood flow to the brain, because you're already maximally vasodilated here, and then drop in pressure just means that there is actually less blood going to the brain, and we know that can cause problems. For sort of immediate control of our blood pressure, we do have baroreceptor feedback that will respond to rapid and dramatic swings in our blood pressure. These baroreceptors operate somewhere in the range of about 80 to 160 millimeters of mercury for your mean arterial pressure. And you have these baroreceptors in your carotid sinus. So these are baroreceptors here, just at the bifurcation of your internal and your external carotid. These send information up to your brainstem through something called Herring's nerve, which is actually a branch of the 9th cranial nerve. So this is glossopharyngeal, surprisingly not the vagus nerve. When you have tone in these baroreceptors, because you have blood pressure, you're going to send signals up through Herring's nerve to your brainstem that will feed back to your heart and allow you to have vagal tone. So this is down through the vagus nerve. The vagal tone will generally decrease heart rate. And there are also sympathetic pathways and feedback that will say you don't need as much sympathetic tone here when you have high blood pressure. So then this can also decrease your SVR by sending relatively less sympathetic tone. These baroreceptors in the aortic arch essentially achieve the same thing. They just send signals through the vagus nerve instead, and are probably sort of secondary in their effect to the carotid sinus receptors. These ones probably more tightly regulate your blood pressure. We should talk about perfusion pressures, because what actually matters is the amount of pressure that is perfusing your end organs. It is not simply the mean arterial pressure, but rather the pressure that is driving blood to any given organ system that matters. So for your brain, it is the mean arterial pressure minus the ICP or your CVP if the CVP happens to be higher than your ICP. Basically, you have your mean arterial pressure that's driving blood forwards, and then at the tissue level here, the pressure from your venous system is essentially pushing back on this. Or if you have high intracranial pressure, this could be the limiting factor to driving blood through capillaries at the tissue level. So to determine the perfusion pressure at the tissues inside your brain, you just take your mean arterial pressure and subtract whatever is higher between your ICP and your CVP. This means, to be very clear, that if your ICP is elevated, your cerebral perfusion will be reduced. At a cerebral perfusion pressure of less than 50, you can start to see EEG slowing, which is slowing down of your neuronal activity, which certainly means that oxygenation is being compromised. And at a cerebral perfusion pressure from somewhere between 25 to 40, you can actually see flattening of your EEG, which is big trouble in terms of the oxygenation of your neurons. Coronary perfusion pressure is perhaps a little bit more interesting to talk about. Your left ventricular perfusion is determined by your arterial diastolic pressure minus your left ventricular end diastolic pressure. Let's break this down. As you may recall, you have coronary arteries. You have a right coronary artery and you have a left main coronary artery, and these go on to perfuse the entire heart. The openings for these arteries are actually in the aortic root. What we have here is our left ventricular outflow tract and a 3-leaflet aortic valve. The opening for these arteries is just distal to the aortic valve. So these are the coronary ostia, and they exist just above the coronary cusps of your aortic valve. So this is your aorta. It's the pressure that exists in your aortic root that drives blood down these coronary arteries, and then will go on to perfuse your myocardium. The problem with perfusing your myocardium is that it's a muscle that is squeezing, and especially during systole, there's very high pressure in the tissues of this heart. So let's show what's happening with these pressures to determine when your left ventricle can actually be properly perfused. So I'll just do a graph here of pressures. Let's say this person has a pretty normal blood pressure, so they're going to be sort of in this 120 on 80 sort of range. And this is this systolic period where we have our rising blood pressure. And then the dicrotic notch sort of marking the beginning of our diastolic period. To be clear, this is the pressure that you're measuring, probably at the wrist or the brachial artery, but is going to be the same as the pressure inside the aortic root. So we're assuming that this is the pressure that's driving blood down your coronary arteries. The pressure in your left ventricle also varies with your cardiac cycle. So low when we're in diastole, and then during the systolic period, it's contracting, and obviously, at this point, the pressure that is ejected from the heart is created by the left ventricle, so it's going to be the same. And then during diastole, again, we have relaxation of our left ventricle, which rises again during systole, and so on. During this systolic period, when there's high pressure in this left ventricle, the blood just isn't going to be able to move. Like, it's not going to go forward because there's no pressure difference between here and the tissue that's trying to be perfused by these blood vessels. So during this systolic period, you really don't have any myocardial perfusion. Here, where your aortic root pressure is way higher than your left ventricular pressure, this is where your left ventricle is properly perfused. So this is where we get our equation of arterial diastolic pressure minus our left ventricular end diastolic pressure, which is technically here, but it's generally reflective of what our ventricular pressure is going to be doing during diastole. We just have to pick some point in time. So it should be very clear that the left ventricle is only perfused during diastole. The right ventricle, on the other hand, is a little bit easier to perfuse because it has much lower pressures. Throughout the entire cardiac cycle, the pressure does not get very high because it's a low pressure system, at least in a person who does not have pulmonary hypertension. A right ventricular systolic pressure of 25 would be quite reasonable. And then again, relaxes during diastole, and our peak pressures during systole for the RV really are not all that high. So during systole, our aortic root pressure, this red line, is much higher than the tissue pressure in the RV down here as it's squeezing during systole. So you're actually still going to be perfusing the RV during systole as well as during diastole. Lastly, we should just go over determinants of myocardial supply versus demand, which comes up very often. The heart, much like the brain, has the ability to auto-regulate its blood flow. And then for the heart, it's between about 50 to 120 millimeters of mercury. The coronary blood flow likes to be at about 250 mils per minute. And with this amount of blood flow, it gets approximately 65-70% oxygen extraction. I should say this coronary blood flow is at rest. So it would be very usual to see an increased coronary blood flow when there is increased demand on the myocardium. Also, by comparison, other tissues have much lower oxygen extraction than the heart does, often sort of in the range of 25% oxygen extraction. So the heart does a very good job of extracting oxygen from the blood that it's sent, and by extension of this, has very limited reserve for functioning properly when its blood supply is compromised or its demand is significantly increased beyond what the supply can handle. Determinants of myocardial supply, as we just talked about above, the coronary perfusion pressure. Here we're looking at the aortic diastolic pressure and our ventricular end diastolic pressure. Heart rate certainly has some effect on myocardial supply, perhaps not as simple as you might hope. Certainly, your cardiac output is often increased by having a higher heart rate, which can be good for other organs, but the higher your heart rate, the more time proportionally you will spend in systole. And we know that your left ventricle is only perfused during diastole, so you potentially will actually have less LV perfusion when you have a faster heart rate, despite sending more blood to other areas of your body. The amount of hemoglobin that you have and the saturation of that hemoglobin is important. If we're extracting 65% of the oxygen in people who have normal hemoglobin and normal saturation of that hemoglobin, if you take a person who's anemic, their oxygen extraction may approach 100%. And if you take a person who's only sending 90% oxygenated blood to their heart in the first place, there's certainly going to be less oxygen for that heart to use as well. These are both very important to optimize. Diameter of your coronary blood vessels is also very important. Resistance is proportional to 1 over the radius to the 4th power. Or in other words, flow that you get through these coronary arteries is proportional to the radius of those arteries to the 4th power. So there is significant exponential increase in flow when you have increased radius and decrease flow with decreased radius of your coronary vessels. So things like coronary artery disease and acute occlusion, for that matter, can dramatically decrease the amount of flow that we can get to our heart. In terms of demand, the basal metabolic requirements of the heart are about 20% of its energy consumption, and then heart rate, wall tension, and contractility are all contributing to the pressure and volume work that the heart does. And that's about 79% of its energy. I think 1% is maybe some electrical activity. So increasing heart rate, increasing wall tension, increasing contractility will all significantly increase the metabolic requirements of the heart. Therefore, it needs more oxygen and it needs more supply.